Hello and welcome. My name is Donna Cryer. I am the founder and CEO of the Global, and I have the privilege of being your moderator for this International NASH Day panel on Beyond the Biopsy, Innovations in Diagnostics. NASH is non-alcoholic steatohepatitis, and it is a serious disease. 115 million people around the world. Early stage liver disease typically doesn't show any symptoms, and so screening comes too late for many patients. And when screening does occur, it is often painful, invasive procedures with multiple risks and potential complications. I know I have gone through that many times myself. The good news is that liver disease diagnostics tools are 20th century technology. And soon technology will make screening and diagnosis for liver diseases easier, less invasive, more reliable, while decreasing the time, pain, and risk to patients. This is an exciting time for innovation, and I have a very exciting set of guests to talk about this issue with us today. But first, just a moment about International NASH Day, which has brought us all here together. Our theme for this year, International NASH Day, is NASH around the world. And so that's why it was more important than ever to bring you experts from around the globe. And you'll see across the course of the day, not only panels on topics across the different, but insights and visuals of how NASH is being experienced by practitioners and patients in multiple countries. We want to be able to give a specific, the Global Liver Institute is so honored that our International NASH Day has received the endorsement of AASLD, the American Association for the Study of Liver Diseases, and EASL, the home of hepatology. We're also astounded and humbled that this year we have endorsements from 11 additional medical societies from around the globe, as well as the WHO. And so without further ado, let me introduce our on Beyond the Biopsy, Innovation in Diagnostics. I could think of no three people who could better explain these issues and get us all excited about the promise of non-invasive diagnostics. We have with us Thomas Berg General of EASL. He's also professor of medicine at the University of Leipzig in Germany. We have Quentin Anstee, who is, amongst his many titles, professor of experimental consultant hepatologist at Newcastle University in the United Kingdom. And we have Professor Vlad Ratsu. He's a professor of hepatology at the Université Pierre et Marie Curie in Paris, France. So often with our Italian team that my French is not what it was, but perhaps by the end of this episode, it will be restored. So I will actually just start with a welcome to you all and give you a moment. My first question will go to you, Dr. Ratsu. So you raised quite a stir, and people have become very excited about the presentation that you made, hashtag. And for me, having worked with you for so many years on this issue now, it was a fantastic evolution of thinking and gathering of evidence in support of the role of non-invasive diagnostics in NASH. And so that evolution and particularly how things over the past 12 months have changed your thinking and your approach to screening and diagnosis in NASH.
Thank you, Donna. Very happy to be here with you. Well, I think I've been through a few phases of enthusiasm and disappointment, and regarding the use of biomarkers in NASH. And I think at the time when we had NASH-TAG, I was rather enthusiastic, but you know, positive and negative results kept accumulating. So I'm a little bit more skeptical today. Definitely biopsy as we know it, meaning the way the pathology was read before, is probably not the way for the future, and we need to replace that with better ways of assessing drug efficacy. Now, there are ways to improve histology, and maybe we'll discuss about that, in particular the pathological assessment. And then there are ways to assess response non-invasively. And I guess that's most of what we will be discussing today. Now, definitely, we do have a lot of non-invasive types of biomarkers or tests or approaches or algorithms. The problem we face is that, broadly speaking, it will be very hard to demonstrate perfect correlation with biopsy. Actually, it will be impossible. That's for one thing. The second thing is that it will take a long time to demonstrate a good correlation with clinical outcomes, because it's not enough just to show these natural history studies to demonstrate that for a clinical trial, for the purpose of a clinical trial. And the third thing is that it will be very hard to kind of be confident enough in the sense that what you would like is that all good, valid, and well-validated biomarkers pretty much give you the same result. Not one says no, the other says yes, the third one is neutral. And I think that will also be a very difficult thing to prove and to optimize. So for all these reasons, I think there's still a lot to do in this field.
Okay, so we'll have look forward to a Beyond the Biopsy Innovations talk like this and on the next IND. But we're making progress. Maybe Dr. Anstee, can I ask you just to back up a step for our audience and just help us think through the sort of types and categories of non-invasive diagnostics. I sort of think of it serum tests, sort of blood tests that we draw information from, imaging tests, AI, and even sort of less painful or just improvements in biopsy itself. Are those sort of the four basic categories that we're talking about?
Hi, Donna. Well, first of all, let me say thank you very much for inviting me to join you today. It's an absolute pleasure to be here. I think you've summarized that very well. There are a range of different types of biomarker, and one of the first steps is to understand how the biomarker performs and to put it into the right context of use. So you use it to answer the right question in the right place for the right person. And that's one of the really big challenges here. In terms of the technologies, and Vlad mentioned this as well, there's the concept, first of all, of make the biopsy better. So we accept that there's a degree of inter and intra-observer variation when biopsies are read. And part of that is due to the individual looking down the microscope. Part of it is related to, did the needle go in an inch to the left or an inch to the right, and would that have changed the outcomes? You can't fix that second one about sampling error with artificial intelligence. But what you can do is use artificial intelligence and computer approaches to minimize the inter-observer variation. And I think that's something we're going to be seeing growing. So number one, make the biopsy better. But number two, and this is the really important one, is move away from biopsy towards non-invasive tests. They have a number of advantages. The big one is they're sampling the whole of the liver or the outputs of the liver. And so, as you say, some of those can be blood-based, some of those can be radiological imaging-based tests. And there are a range of both of those. We've got quite good tools now for assessing fibrosis, but they're not perfect. We're less good at differentiating simple steatosis, NAFL, from NASH. And that's an area we need to get better, and there's a lot of work going on there. And that's the same whether it's a wet biomarker, a blood-based biomarker, or an imaging biomarker. But we're getting there. And I think, as Vlad said, there's some room for optimism here. And certainly in the next year or two, I think there's going to be room for a lot of optimism in this area.
Well, you're certainly working. I can testify to everywhere in the world, and so I have great hope that we're going to get there. And should I ever need more examination, we can stop at the 6 biopsies I've already had and of these new tools. So, Dr. Berg, how are you seeing the evolution of non-invasive diagnostics, or even making biopsies better, play out in your practice, in your...
Yeah, Donna, thank you again, and thank you also very much for inviting me to this fantastic meeting. You know, I fully agree with what has been said by Vlad and Quentin, but I think it's, you know, this biopsy is a one-point analysis, and quite often we can underestimate the progression rate or the risk of disease progression. I think this is really the most important one, that we had assessment that help us how to best follow the patient. And I think we have a lot of experience with the hepatitis C field, and biopsy was not a good decision-making tool for whether to treat or not, you know. So, and therefore I'm quite convinced that by these simple non-invasive tests, we will succeed. The most important point here is really to bring the patient at need to a specialized care, to a specialized centers. And I think they all have all the measures, they have all the tools to see whether there's disease progression or not.
On that point, Dr. Berg, you know, as we think about care at whatever point, at the screening point or at the treatment management, for over 100 million people, and that's just NASH, you know, there are many more times that with some form of fatty liver disease, is driving people to a specialized practice. Is that the point of the exercise? Is that the outcome? Or is there an opportunity with non-invasive diagnostics to bring care to communities and decentralize at least some parts of this, so that more people can be reached? And then for those with advanced disease, making sure we are getting advantage of those to the specialized centers, you know, to hepatologists to deal with that. Can we do a better job to, you know, profile and segment the people along the degrees of these, and make sure that we're getting the right people to specialized expertise? Is that more of where we want to go?
Yeah, if you ask me, I think this is, well, this is of course a challenge, as you mentioned. If nearly a quarter of the world population is affected by some degree of fatty liver, and we know not all of them, of course, will have a progressive liver disease, although there might be other risk factors. So there's a lot of training of the primary care physician, and we need these thresholds, these cut-off, especially when it also comes to follow up. Perhaps not only a single non-invasive assessment with the primary care physician, but if they have done it twice or 3 times over a certain period of time, and still the values are above a certain threshold, I think this should justify for more specialized care.
I would definitely, as a patient, be willing to multiple times during the course of a year or 2 years for blood work. You know, I get blood work every month as a liver patient, so that's no problem. Or imaging. I'd certainly be willing to come in every 4 months, every 6 months, assessment for imaging in a way that I wouldn't do for biopsy. And I don't think many patients would be, you know, adherent to something like that outside of a research setting. So this issue of to make sure that we are expanding access and even improving our surveillance. You know, I can't address solutions unless I really understand the number of people affected by the problem. And I think that we've been hampered by an over-reliance on to understand who has NASH as a whole. So, Vlad, I'd love to ask you, as you, even in your skepticism, that's certainly helpful. as regulators on how they should be assessing these non-invasive tools, on their own and as part of NASH drug development. So what do you think that the regulators should state of non-invasive diagnostics, and how close we are to being able to rely on them in a research setting, or for drug development purposes? What is the role of non-invasive research right now, and what would you tell the regulators?
Well, there's a large European consortia called Litmus trying to work towards qualifying these biomarkers, and I think that Quentin, who had a lot of interactions with the regulators, would be a better person to answer this. It seems to me that, like always, they want proof from well-designed prospective trials that these biomarkers are useful in situations and circumstances that are very well, clearly and precisely identified, which is what they call context of use. The problem is that I'm not sure, and Quentin will give his opinion on that, whether retrospective studies will be sufficient, or if they want truly new studies designed specifically to answer that question, in which case it will take some time. Now, hopefully all these large international trials in NASH do collect many types of biomarkers. We could have, if there is good collaboration between companies, we could have some answers rather quickly. The level of certainty coming from these analyses will be the major determinant on whether this will be accepted or not, because we won't have 100% concordance or accuracy with the results obtained by biopsy, which are now the gold standard for assessing efficacy in drugs. So I think I'll stop here, and Quentin certainly can give you more about the interaction specifically with the agencies.
I will turn it over to Quentin. Just a provocative question, perhaps. I know biopsy is called the gold standard, but we know it has its own limitations. And so, is there so much value in referencing a new technologies to a limited a limited technology? So referencing something doesn't seem to be the best thing, since biopsy itself isn't perfect. It just seems like there's something logically problematic with this whole process. Answer to my concerns. Can you better articulate them?
Yeah. So, I think there are some historical and psychological dimensions to this. And the issue with the biopsy is that we've been used for so many years with biopsy as a diagnostic tool. Biopsy is something that you can see and measure objectively. It's something that gives you a result, not a range of possibilities with predictive values or sensitivities or specificities. It just gives you the result. And in that sense, given the whole historical baggage, there is a psychological obstacle to going beyond the biopsy. Now, it would be easy if the biomarkers would be clear cut and very performant, like measuring viral load in the serum. But it's not. And it's not. Why is it not? Because they all have a lot of biological variability, a lot of operator variability, and plus they have been calibrated on the biopsy itself. So the fact that you don't have a strong independent alternative makes it very difficult to let the biopsy go.
But I will keep asking us to do so. Quentin, your market litmus.
Maybe no. Well, maybe I can come into this because I think there are a couple of things here we need to think about. So Thomas made a really good point, which is that actually we do have some biomarkers, and in terms of pragmatic use in routine day-to-day clinical practice, we have some valuable tools available to us right now. And it's then about applying those, getting those out into the community to help us find the right people, to triage them, and to work smarter. And there are a range of, if you like, off-the-shelf biomarkers and diagnostics that are available right now. And we need to move from a slightly chaotic approach to finding people to better approaches, more systematic approaches to finding the right patients. And so that's something that we can do right now. The second part is that movement in terms of drug development. And again, Vlad made the key point here. We're emotionally tied to the baggage that is liver biopsy. And part of the reason for that is because it is biopsy for which we have the best long-term data in terms of a fibrosis score of 3 or 4 gives you a certain degree of outcome. And so it's for those reasons that right now we tie our biomarker development to biopsy. In the fullness of time, as cohorts get more mature, and I'm thinking about cohorts like the European NAFLD registry that was initially sponsored by EASL, was funded by the EU in the FP7 FLIP program that Vlad started, then in EPOS, and now latterly in Litmus. As those cohorts mature and get longer, sadly, it means we acquire more events and we develop outcomes on patients. Now, that's not anything any of us want, but of course, it allows us to build a better data set to inform our use of biomarkers in the future. So that will come with time. But right now, in terms of can we better find patients, can we work smarter in routine practice? Yes, we do have tools, and it's a question of getting them out there and getting them implemented in practice.
Excellent. Dr. Berg, would you like to weigh in on how the limitations of biopsy and but the reasons that it's still used? Because it's a question that I get from patients who are encouraging to participate in clinical research or simply to go seek care, and in this state of transition, they're asking, well, what's the value of me getting a biopsy, today? And so how do we explain the value to us today?
Donna, you made a very good point, and I think it's clear when we will have licensed drugs, hopefully. I don't know when, but I think it's, the likelihood is increasing that we will have drugs. Then, of course, it might be restricted to a certain level of fibrosis or so on, but we need, before we have these licensed drugs, we need more data. And also from a regulatory perspective, and we discussed it, we needed to include the patients in these studies to get drugs licensed. So it's really, in a way, we need to convince that it's a transition phase, but for this transition phase, that we are quite sure that these drugs are really working and they fulfill what we want that they do. We need this. So it would be very good if patients agree on that and are willing to be part of these clinical trials. And you see, it's still not so easy to recruit patients for these trials. We have so many patients with fatty liver disease, but when it comes to those with more advanced disease, it's not so easy to find and to recruit as rapidly as we want in order to have a faster drug development program.
It would seem at least two issues that I've observed and heard from patients. One is reluctance to take a biopsy, and maybe we'd actually sort of walk through what a biopsy entails for our audience here. But then often people become too sick to participate and have to drop out of a trial, particularly if they have advanced disease and cirrhosis and complications. They may develop liver. And so how do we ensure that we have enough patients in trials, allowing for dropout rates for a variety of reasons into the trials. And so that's something that we'll definitely work on. And I know one of our new resources for this International NASH Day is what is it like for patients to participate in a NASH trial, to give them those insights, sort of better know what to expect, and are hopefully more likely to say yes. But Dr. Berg, if I could ask you just to walk through what does it mean to have a biopsy? What actually happens, and how long does it take? So, a patient and their caregiver, I guess, they drive to the hospital that morning and have a biopsy. What goes on?
Yeah, I think there are different approaches in different countries or clinics, but normally you have to stay for 1 day. Some patients do it, some clinics do it just with 1 day. So you come in the morning without having any breakfast, and then you get your liver biopsy, and then some of them, they will be discharged after 4 or 5 hours if you see everything is okay. And in other clinics, they will stay overnight. So it's not really a big thing to do it. But of course, and I think we are quite aware of as physicians, this invasive testing really is the last thing we do, and we need a good reason for that. And for the moment, it's really that we can offer a patient a new drug. When he has advanced disease, there's no licensed treatment at all. And I think this is a good reason for doing this invasive test. If it only comes to see what, let's say, stage of the disease is, I think in most of the special centers, with all these non-invasive biomarkers, we have serum tests, we have the fibroscan, elastography, ultrasound, and so on. I think quite often we can judge whether it's really going towards cirrhosis or not.
And most biopsies done today, ultrasound guided. I'll just have to admit, I'm 26 years post-transplant, so most of my biopsies are, in the old days, really long needle. They sort of looked at me between the, we went in there before, they draw on me with a little marker, and they just go sort of cha-chunk, and then they're like, lie there on your side for about 6 hours so you don't bleed out. Bye-bye. So that's been my 6 biopsy experiences. But I know that there are transjugular, ways. So can you just discuss this a little?
Yeah. No, you explained it quite well. We will not do it the transjugular way. We only do it the transjugular way if you have a very compromised blood coagulation, very advanced disease. And also the amount of liver tissue you get is normally less. Also for staging of liver disease, it has some issues. Yeah. So it's
okay.
As you have experienced.
So I think that people have been. Yes, Vlad. Go ahead.
I kind of would like. I'm in a mood today of defending a little bit the liver biopsy, though. So.
Okay.
So the question is. The question is very different depending on whether you look at clinical trials and drug development, or you're looking at everyday life. It's clear that, and then the question is also different depending on how many times you do the liver biopsy. Because what I find is that sometimes doing the liver biopsy to provide a diagnosis to someone can be important. I mean, there's a lot of people are exposed to risk but don't have severe disease. So it's very reassuring to prove that there is no severe disease or no risk of development or very low risk. That allows you to concentrate on different ways of managing the disease, non-pharmacological, diet, lifestyle, etc. So yes, some people do not like to do the biopsy at all. Some others are accepting it with disconcerting ease if you do it once. and then in clinical trial, and then of course, if that gives the opportunity to have access to a drug in a clinical trial, that's another reason why people would accept it. Now, what happens in trials is that once once the patient has been through 1 year, 1.5 years of treatment, they do accept the second biopsy, in my experience, quite easily, because they want to find out whether there was improvement or not. The problem in clinical practice, though, is that not so much you can't do the first one, but it's very difficult to repeat it just to find out whether the patient gets better. And that's where you need biomarkers. Mm-hmm. And in the end, you might not need perfect biomarkers, but you might need one that is sort of, even if it's imperfectly correlated with a biopsy, at least that changes somehow in the same way as the biopsy. And then you can follow the patient. But so in clinical, and then in clinical practice, as we do it today, we don't have drugs yet. I think you can manage without a biopsy if you want to do trials, if you do not want to do trials, sorry. So you can manage that in clinical practice. Now, in trials, you have to go through the biopsy for reasons we have seen, but it is something that can usually be negotiated with the patient. Yeah, so I'm going to stop here, but yeah.
So let's go through all these sort of concerns and myths, perhaps, that might dissuade someone from getting a biopsy and thus participating in a trial. Some may have heard that yes, a biopsy gets information, but in a disease as heterogeneous as NASH, one stage of disease at the place where they biopsy, and liver cancer 2 inches over, or 6 centimeters over. So what do you say to that? To assess
very briefly, yeah, and then the others will speak as well. Yeah. Well, liver cancer, fortunately, we have different imaging methods that are quite performant in diagnosing most of at least the nodular forms of cancer. So that can be managed, and you have to do these imaging methods anyway. Regarding the sampling variability, I still don't know and understand exactly what that means. I mean, is it just the biopsy that misses the lesions, or is it that truly throughout the liver, especially in earlier stages of the disease itself or the fibrotic sequelae is heterogeneous? So even if you don't do a biopsy and you just open and cut the liver in 1,000 slices, you would see places where it's F1, places where it's F3. So then how do you conclude? Is it more F1? Is it more F3? Is it in the middle? If the disease itself does not spread through the organ in a homogeneous way, the problem is not so much the biopsy. The problem is how do you stage the disease? Right.
Quentin, you smile, so I'm going to let you pick up on that point.
No, absolutely. I mean, this is all about, this is going back to those days in maths class where we were trying to guess how many yellow socks you had to pull out of a drawer in a power cut to be sure of getting a matching pair or whatever it was. And I think Vlad makes a really good point here. We know, and actually it's biomarkers that have helped us really get a handle on this. We know that the disease in terms of fibrosis is a little bit heterogeneous throughout the liver. And MRE has been one of the tests that has helped us do that, because it's been able to look at a slice through the liver and see differences in the stiffness of the liver in different places. So we know that's certainly the case. However, when you are taking a sample out simply on the basis of probability, you're likely more often than not to hit a piece of the tissue that is representative of the majority of that tissue. That would be my interpretation of it. But of course, you can always sometimes get sampling error, and that's where the variation in biopsy comes. So, like Vlad, I am a fan of biopsy. It has a place. It particularly has a place when there's diagnostic uncertainty. So all this talk about biomarkers, it's about grading and staging disease. How active is it? How much scarring is it? It doesn't answer the question, is this NASH? Is this autoimmune hepatitis? And for something like that, that's when a biopsy really comes into its own. So it's horses for courses. We need to use the right test at the right time.
I love that.
And
Dr. Berg, yes.
yeah, may I add, I think an issue with the biopsy is also that it's not really predictive, you know? And so even if you have a pure steatosis without fibrosis, ballooning, and so on, you might see progressive disease 5 years later. So, and I think this is really a very important point. So it's always also the question when it's the right timing to do the biopsy, you know, because patients do not want, as you mentioned, to have every year a biopsy to see whether it's progressive disease or not. So it might be that if you have it quite early in the stage of the disease, it's a quite mild result, and then everyone is relaxed. Well, it's only mild disease, but what does it really mean in the long term? And normally patients with non-alcoholic fatty liver disease, it takes decades until it comes to a very advanced disease. So this is also, I think, an issue we have really to keep in mind, the right timing for the biopsy.
Yeah, I think if I can say, I think Thomas makes a very good point in the sense that it's not all about the staging of the disease, but understanding also factors that might not be related to histology itself that predict the propensity to progress in this disease. And those might be things that are independent, right? The level of insulin resistance or age or the activity of the disease and so on and so forth. Because this argument, you could use it for anything. You could use it for ostometry. It's not because you have 5.3 kilopascals today that you might not progress to more in 5 years from now, as you said, if you have a certain number of factors that accelerate disease progression. So I think what you say raises the very important point of trying to understand beyond some well-established histological parameters, which are the factors that determine disease progression. Now, also, I think we should ask Thomas Berg, because, you know, he was involved with viral hepatitis, okay? Viral hepatitis 20 years ago, 25 years ago, people were relying a lot on liver biopsy, including for trials, including for registration trials. And then progressively, the focus shifted away from the biopsy with the HBV antivirals, with the HCV antivirals, to the point where in the recent years, the need for histological assessment and even the need for staging totally disappeared. Why? What determined that change in terms of our tools, in terms of disposal of tools to understand the disease? And I'm referring to virological tools as well. That would be an interesting historical parallel between NASH and the viral hepatitis. Absolutely.
Dr. Berg?
Yeah, that exactly. And I think you are aware of it. It was the testing of the viremia. So we had a test where you can detect whether the virus is present or not. And in the beginning, also the drug agencies were not willing really to believe that the surrogate virus is present or not make a difference. So in the beginning, they want to see a liver biopsy showing that there's inflammation is going down. But then there was so many proof of this concept that if there's no virus, there's no disease progression, at least no disease progression from this viral hepatitis. And in the same way, we need these markers for non-alcoholic fatty liver disease. And I would be really interested in your opinion about these simple liver enzymes. So the AST, the ALT. So if you have a patient with 2 times upper limit of normal ALT, I think the likelihood that he will progress, this patient will progress, is quite high. But what, when by a drug or by losing weight, the level comes down to very normal? Would we rely on that? Or is
so
it?
I will let Quentin answer this. But before we move to this, just to finish this historical perspective, do you think that if we did not have an accurate way of measuring viral load, and if we had to rely on histological improvement as a measure of efficacy of the antivirals in HBV or HCV, do you think we would have been here today with all these drugs we have for that assure cure of the disease or long-term control of the disease? Do you think we could have done that with the liver biopsy if we did not have viral load?
No, I think it's not practical. I do not believe in liver biopsy in the routine use. Perhaps in the beginning that you see that's the right indication because, you know, it's also a matter of the price of these drugs, we will see. But then I really think these biochemical parameters and these simple ALT could be a good predictor. You know, there was a long-term discussion with the cholestatic liver disease called PBC, primary biliary cholangitis. But now I think it's quite convincingly shown if you have normal cholestatic enzymes, then the likelihood that you have progressive disease is quite low. And I think it could become quite similar for non-alcoholic fatty liver disease. A bit more complex, I agree, but the concept, I think, would be the same.
We certainly have had that conversation with primary care physicians who are really grappling with a very simple tool or formula or mechanism to put into their clinical workflow as we're asking them to diagnose and manage patients. And so an AST ALT ratio is certainly very attractive because they already have those information to that data. So Quentin, I'm interested in your thoughts on that. And
absolutely. So I think there are a couple of things to think about here. And first of all, to one of Thomas's points, I'm not sure how much we can extrapolate either from the viral hepatitis paradigm or indeed from the PBC paradigm into fatty liver disease. If we take a step back and think about the pathophysiology for a moment, in hepatitis C, there was a clear infectious pathogen that was driving the process. In a condition like PBC, although we haven't pinned down all the details yet, it's an autoimmune-driven process. In fatty liver disease, however, we have this overwhelming complexity of insulin resistance, of lipotoxicity. You can get to the same endpoints through any number of different metabolic imbalances. So I think we have to be a little bit wary about drawing too much on past experience there. And I think that was what Vlad was touching on with his point about biopsy for hepatitis C. If the hepatitis C field had never developed an assay for that one injuring pathogen, it would have been a much more difficult job to develop effective therapies. And in fatty liver, we don't have that one single pathogen. So we need to bear that one in mind. The second thing I think we need to be thinking about is to that point about standard routine liver biochemistry, so ALT, AST, and so on. We have got good data that actually absolute values of ALT, for example, do not correlate well with underlying liver disease. So you can have a normal ALT with a very active steatohepatitis or advanced fibrosis. So I think we need to be very careful about sending out a message that a normal ALT, all is well, because that is sadly not the case. In fact, we know that if I had NASH and we watched me over the next 5 or 10 years progressing to cirrhosis, we would see my ALT level fall as my disease got worse. So we have to be very careful about that one. Now, where things get more complicated is when we go back to the clinical trial. If you have an intervention and suddenly things improve after that intervention, we are seeing some data to suggest that that correlates with improvement. So a great example of this would be significant weight loss. Okay, so you often at the time, if you, for example, use a very low calorie diet, 800 calories a day, it's an extreme diet, weight comes down. There's a flick of ALT in the first 10 days as you get mobilization of fat from the liver, and then it rapidly falls as the liver disease improves. In that paradigm, it is probably quite a useful tool. But but as a long-term monitoring in routine practice, I'm afraid it's going to mislead us more often than it will help us.
I think one of the first things that I remember writing at the very first NASH Council meeting at the School of Public Health was liver enzymes lie. But perhaps they can tell us a little bit more of the story or get us closer to the truth.
It comes back to that. Be sure to be asking the right question at the right time. So liver enzymes lie sometimes if you ask the wrong question. Other times, when you ask the right question, they can help you. And I'm afraid the devil is sorting out which of those we're dealing with at any one point in time.
That's why we have hepatologists. If he didn't need to manage patients, and we wouldn't want that. We wouldn't want that. Since I am more patient than lawyer these days, and leader of a patient advocacy organization,
I'm not sure I agree. You're doing a wonderful cross-examination here of three of us simultaneously.
I have only one hostile witness over there, but so you make it very easy. How can we help as the Global Liver Institute and patients, listening to this, wanting very much to get beyond the biopsy? What can we do? I know, we are very happy as GLI to be supporting, the litmus, Nimbus. I combined you. The Nimbus. That's my thought for the day, that we can all work together. But certainly supporting, both efforts to help with the biomarkers, encouraging patients to participate in clinical research, raising awareness on International NASH Day, and hopefully throughout the rest of the year. But are there other things that patients and patient advocates can be doing to help all of the work that you're doing? Maybe Quentin, Dr. Berg, and Vlad?
Yeah, I mean, Donna, I think there are a couple of things. The first, and you said this, is join in with clinical research, because patients engaging with it, taking part in registries. So there's the European NAFLD registry in the EU, and there are, I'm sure, similar efforts run by the NASH CRN, for example, in the United States. So taking part in those registries. Sadly, at the moment, having a liver biopsy will help us get rid of having liver biopsies, because so there is that slight conflict right now about that one. But taking part in clinical research, taking part in trials of therapeutics, if you want to, and if your physician feels it is advisable in discussion with you, it is something that can really help. And then getting the word out there. There are so many people still who don't realize that they have fatty liver disease, and both clinicians as well as patients, it gets minimized. Oh, it's just a little bit of fat in the liver. I'm afraid it's not just a little bit of fat in the liver till it's been tested and demonstrated to only be a little bit of fat in the liver. And that's an important point.
Oh, sorry. Donna, I very much believe in the patient being well educated, and quite often I'm surprised when I ask the patient, what about your liver enzymes? Do you know whether they were elevated 10 years or so? That they were not really aware of, although it was measured. So I think the patient need to know their liver enzymes. And if they are elevated over a certain time frame, let's say for 1 year and in the second year, they should really ask the family doctor, well, I want a diagnosis. This is not normal. And then it can come to specialized care. And I think this will help, because quite often there's no referral, although there's a long lasting, and then you get in a way used to it. Yeah, it was always like that. But 20, 30 years later, then you have the advanced liver disease, and then it's perhaps a bit too late to do something again. So I think this would be really very important to give this message that you're also responsible for your health, and take it serious and that a diagnosis should be made. I think this is the most important thing, because most patients with fatty liver disease do not have this diagnosis, and therefore also the family doctor, the general practitioners do not know what to do.
I think that that's a very important point of patient engagement and partnership with physicians. We did a special graduates from our Advanced Advocacy Academy on accessing your patient portal. So, how to find all this data about yourself online now that's made accessible. So where do you find these lab tests that you've been taken? And I certainly appreciate that I get an alert when they come in, when that didn't used to be the case, before. And so now that we have access to this information, we have to use it to start conversations with our physicians. So Vlad, what can advocates be doing to advance this field and help you in your work?
There are several things that were said are extremely important. I think, as Quentin said, so first, yes, awareness about the disease. People should, if they're at risk, should ask their physician to check the liver condition. That's very important for sure. Second, explain to them that it's not a disease where you have symptoms. So you don't have symptoms. Let's make it simple. There are no symptoms, despite what, a lot of descriptions of things that are due to some other things, but not to the liver disease itself. So there are no symptoms, which means that you cannot assume that everything's perfect because you have no symptoms or no pain. Very important to educate about that. And you can have even kind of sort of advanced disease while feeling perfectly well. And there are other circumstances in medicine where that's true as well. Kidney failure, renal insufficiency is just the same, right? Even worse. So that's another point. The third thing about participating in clinical trials, as Quentin said, extremely important. Educate patients that they're not serving as guinea pigs, that there's a whole process of making things move forward in medicine, in science, for their own benefit, sooner or later. Very important to explain. Sometimes patients sign up for protocols for clinical trials, then they go to speak with some uncle or aunt or their general practitioner, which is even worse. They come back saying that they don't want to be guinea pigs and take their consentment back. So that is important. I would not so much fight on the liver biopsy so much thing. I think there are things more important than that. And I think the most important thing, once we have said everything we've said, it will be when we will have drugs on the market or very close to being approved, is to really push towards those drugs to become available. Because the way I see it, it's going to be a very hard battle, because either the regulators will say, well, okay, there's some improvement, but not sufficient to prove that you save lives. Or the payers will say, which sometimes can be the state, for instance, in our country, will say, well, we're not going to pay because the benefit is not sufficient. We have drugs now for second-line primary biliary cholangitis treatment that are now available on the market for now 2 years, still not being reimbursed in France because the benefit they have shown is considered insufficient. So this is where patient associations should start working, because if that happens all the time, drug developers will just abandon NASH.
I think that we have been, very engaged in ongoing conversations with payers, with value assessors, and walking that centric value frameworks would look like, so that we can have the evidence to present on benefit and risk, certainly from the patient point of view. And we look forward to scheduling our patient-focused drug development meeting the fall, so that we can better quantify what risks and benefits and trade-offs that patients are willing to take in a NASH medication, and better articulating the value that we patient for this serious medical condition. So, any last thoughts? Anything we haven't asked, unearthed, or addressed before we sign off? Had a robust discussion.
Well, if I may, we talked a lot about biomarkers and what could predict disease progression. I think something that might be also interesting for the patient are the genetic risk factors, and they're perhaps underestimated in their importance. And I think they will play a certain role because of the very big number of people being affected by fatty liver disease, but the likelihood of disease progression and also hepatocellular carcinoma is clearly linked to genetic risk factors. And I think the implementation of these easy to obtain tests, it's just a blood test, could really be also in a kind of a game changer. But there's, again, a lot of reluctance in doing genetic testing. You know, how many decades after the discovery of the human genome, we are not using really this information. But I think for fatty liver disease, it could really be very helpful.
Being married to a geneticist, those are, you know, fantastic words to hear. I embrace those, that recommendation. And I know that we will discuss that more, particularly on the panel in NASH in lean individuals. So everybody who's watching, look forward to that. I just want to thank this panel, Beyond the Biopsy, Innovations in Diagnostics, for all of your fantastic insights and conversations. You made it very easy as a moderator. I really just had to sit back and let you all question each other. So I really thank you for such a robust discussion. Information on the rest of our panels for International NASH Day, our videos from all of our partners around the world, from the WHO, from our medical society endorsers, and for our NASH culinary event, please go to the globalliver.org website, or find us on Facebook, on Twitter, on Instagram, Global Liver Institute, and on our dedicated international-nash-day.com. Other additional website. So any place you look, we're there. And we look forward to finding you. So thank you so much. Stay well and stay connected.